I'm glad that I had the opportunity to come to the Autism Society conference. This is a landmark for me because I've been talking about this stuff for 15 years. And this is the first time that the Autism Society has invited me out to do this presentation. I've been at Autism 1, 4 years, whatever, and various other places. And what I'm trying to do is just get out the truth of what I've learned over the last 20-some years as a psychologist in Pennsylvania about how funding for autism treatment and virtually every other condition can be obtained through the EPSDT mandate of Medicaid, early and periodic screening, diagnosis, and treatment. In 36 states, it's available to kids regardless of family income. Pennsylvania is one of them. I'll show you a website that you can look at the list published by the Kaiser Family Foundation to see if you're on it. Ultimately, 3/4 of the United States falls into that category of assistance. It's called medically necessary eligibility as opposed to categorically necessary or categorically needy. So we have a medically needy population. Children with an autism spectrum disorder and virtually every other disability are eligible for enrollment in Medicaid as a result of that disability if they're under the age of 21. And their family income is literally not counted. They're considered a family of one, for lack of a better description. Adults in Medicaid, adults in the regular insurance world, are treated kind of shabbily. I mean, it goes without saying, the insurance people are in business to reduce or eliminate funding. That's why they exist. So if they can get away with doing that, they're going to do it. That's their role. The problem with that role in the realm of EPSDT, and I'll show you the federal and in Pennsylvania, the state statutes that prohibit that activity for children under 21 who are covered by Medicaid. It's actually against their civil rights to be denied access to treatment, quote, that is sufficient in amount, duration, and scope to reasonably achieve the purpose for which it is furnished. That's a civil right for disabled children under 21 covered by Medicaid. So how do you reconcile that with mandatory managed care? They are irreconcilable, and that's the problem. Nobody knows about the other side of the law, the one I just quoted, and everybody thinks managed care for kids on Medicaid covered by EPSDT can be treated just as, I don't know, that the managed care people have just as much power on that side as they do everywhere else in our lives, and they don't. And that's the purpose of my presentation here. What I'm going to talk about, EPSDT benefits, is like ice cream. Every state is mandated by federal law to have ice cream. Now, some places put a lot of nuts in it, some places leave the nuts out. Actually, I think everybody has a certain amount of nuts in it. But it's strawberry here, it's chocolate there, it's various other kinds of flavorings. But ultimately, it's mandated under federal law, part of the Social Security Act, part of the Medicaid statute within Social Security, and then if we take the little babushka doll even deeper, there's this little kernel in there called EPSDT, early and periodic screening, diagnosis, and treatment. It's been described in federal law as a program within a program. And when I do these talks, I can spend a day talking about this. So I'm going to give you the bird bath version, a mile wide, inch deep. There are a number of handouts in the back, especially some of them geared toward Pennsylvania, because that's where we're meeting. And I've been a licensed psychologist in Pennsylvania since 1981. I'm certified in school psych since '84. So I've been at this for a long time. And I gave up my day job about 20 years ago when a woman named Sharon and we were working together at one of the residential treatment centers. And I was about to get licensed, and I thought, okay, I'm going to actually supervise an unlicensed professional under my scope of practice. This is my dream. So Sharon and I worked it out that with her background of being a parent of a young child and her working in the field, she would be a perfect person to go into a home, talk to a mother, work with the child, perhaps in the child's school, and work this close, literally, with the child, go where the kid goes, etc., and then over time get farther and farther away until the child could function independently, more autonomously, etc. So it made perfect sense to Sharon and I, and we put it into play. This is 1981, and it worked. And one after another, families found out about this, and I suddenly had an opportunity to quit my... No, I didn't. The State Board of Psychology rode in. It wasn't a white horse. They rode in and said, oh, no, stop this. She doesn't have half of a master's degree. Therefore, you may not supervise her any longer. It was 1985. So I put the whole program to sleep and found a person with 3/4 of the way through her master's program, and now she could go into doing the same thing that Sharon used to. Sharon had a bachelor's degree, but she didn't meet the cut. So I started doing it piecemeal with this second person, and it worked with her as well. And little by little, I came to the end of my rope in the residential institutional world and just said, I'm going to try to do this full time. This is as the wave of managed care is cresting, okay, 96. So I quit my day job. I was working with the state at the time, and said, you know, I'm going to do this because all of the reading that I did about what's available for children says this is an entitlement under federal law with state mandates. Why don't I throw my lot in with that as a funding stream? I've been doing it. I know it works. So that's what I did. And that was in 1996. And I began supervising a small group of people. And it worked out, and I quit my day job, and I've been doing it ever since. And right now I own the largest psychology practice in the state of Pennsylvania that is exclusively devoted to work with children. And we do 90% of our income funded through the EPSDT mandate of Medicaid. And because Medicaid is a national program with state and federal collaboration, it is theoretically possible to do what I've been doing for 20 years in every single state. And that every child with a mental disability is qualified to be a recipient of Medicaid in 36 of those states, regardless of family income. Why isn't everybody embracing this as funding? I mean, we heard the two state, the congressmen today, Doyle and Chris Smith, talking about we need to do more to treat children. Well, stop. The money's already there. It's been allocated since 1967. It's been a federal mandate in all 50 states since 1989. So we don't have to pass new laws or lobby legislature. All we have to do is say, look, the laws exist. You guys may not like it, and every single state is desperately trying to keep me quiet. That's for damn sure. Even Pennsylvania. The bottom line is, this is the greatest treatment funding secret that has ever been created, and it's been around for more than 30 years in a fully functioning, ready-to-go kind of a way, and it's been tapped in Pennsylvania much more vigorously than in any other state. This is why people are saying, geez, I wish I lived in Pennsylvania. And what they're not getting is these services are an entitlement to Pennsylvania residents as much as they are to residents in your own state. So the question is, what do we have to do to make those entitlements available? And I have some recommendations for that. But that's the background of what I'm going to be presenting on. You have to become strong in terms of your sense of how to advocate for your child's entitlement as a civil right under the Social Security Act in order to get this in any other state. In Pennsylvania, there were 2 civil rights complaints filed in December, just this December, which effectively derailed an attempt by the state of Pennsylvania to redesign the BHRS program. They basically pulled it all off the table in response to the charges that were made in those Office of Civil Rights complaints. The complaints were against the state of Pennsylvania for failure to implement the Medicaid Act and the EPSDT mandate, and to fail to give children adequate access to the supports that they're entitled to under federal law and state law. And the state had plans to gut the system even more so than they have already. And as far as I can tell, those plans were thwarted. They have a draft bulletin where they're proposing amendments to the process where you can't deny a child access to therapeutic staff support just because you think medicine is a better solution. That's not viable. You can't deny a child access to mobile therapy just because outpatient treatment may exist in the community. So these are all things that are affirming the legitimacy and accuracy of the EPSDT mandate, that the state is finally saying, yeah, okay, fine. We're not going to fool around with that. But it's still in a draft bulletin stage. So they haven't actually authenticated anything. So it's this relentless tug of war back and forth. The state will say things that are unfounded. There are no studies, no research. They'll even claim that there is no research that BHRS has any efficacy whatsoever, which is an out-and-out lie. The bottom line is they do everything to suppress awareness of it and access to it. And the extent to which they violate the civil rights of children is the determining factor in what they can do, and that's true in all 50 states. So let me continue with this little presentation. Just by way of giving you some idea of my credibility, this is a letter that was received from Cindy Mann, who's one of the directors at the Centers for Medicare and Medicaid Services in Washington that oversees EPSDT. And Cindy said basically, my staff has spoken with Mr. Kossor and we learned that he has indeed developed an effective approach to serving children and adolescents with developmental disabilities and has made the approach available to Medicaid-enrolled children through EPSDT. This is effectively an endorsement. CMS doesn't do endorsements. This is as close as you'll ever get. Further, the Department of Health and Human Services, this goes all the way back to January of 2001, it says state Medicaid programs must make EPSDT services promptly available for any individual who's under 21 and who is eligible for Medicaid, whether or not that individual is receiving services under, and then they talked about approved HCBS waivers. I want you to understand the difference between a waiver and EPSDT benefits. This is a waiver. It's a box of breath mints. There's 50 of them in here and they're free. And the state wants you desperately to take it and say thank you. That's a waiver. Subject to financial limitations, waiting lists, all those kinds of things. On the other hand, this is EPSDT. It's a credit card folio. It's got an unlimited balance, and I mean unlimited. It has no limits whatsoever because any child birth to 21 who has a disability that can be treated under EPSDT, if they're enrolled in Medicaid, they get the credit cards. That's federal law. So you're a state administrator. Everybody rattles the waiver box. Nobody talks about the credit cards, and that's what I'm doing. Now, it goes without saying that you can't be irresponsible and just criminal wrong about the access to those federal and state dollars. That's public funding. You can't have unscrupulous people throwing services out so that they can reap benefits that really accrue to no one but themselves. That's fundamentally immoral. That's not what I'm advocating. I'm a licensed professional. I directly supervise the delivery of medically necessary treatment services to children who are disabled and enrolled in Medicaid. I'm using evidence-based practices, including applied behavior analysis, in every treatment plan I write. I have assistants, people under my scope of practice, who do most of the writing. But me and 5 other psychologists will supervise that work directly. I meet with my staff 2 to 3 hours a week, the master's level people who supervise the bachelor's level people. So these guys are not by any means on a very long leash. We have clinical supervisors that monitor their writing to make certain that the clerical errors that are so common in the professional work, you'll see Mary referred to as Bob. You can't do that. But it's common in the professional work because psychologists are typically used, frankly, as rubber stamps. They go around to various entities doing evaluations and they see Bob for a half an hour, then they see Ed for a half an hour, and the next thing you know, it's bed or Ra. You know, they don't remember these things, and it's not necessarily that they're incompetent, unethical, immoral, none of that. They're being used, I think, inappropriately. But even if you have an ethical, competent psychologist doing the best they can, if their total investment in a kid's life is limited to an evaluation, even if it's a 3-hour ordeal, that's all they're contributing. They're not monitoring the ongoing delivery of service. They really have no responsibility. And this is the problem with Medicaid. It's especially the problem with the EPSDT mandate because it literally creates this wallet full of credit cards. Somebody's got to take responsibility for that. And that's the model I'm proposing to you. I figured out how to do it. I've been doing it for 20 years. It can be done in every state, just as economically, as efficiently, as successfully as I've been doing it. 90% of the kids we work with are finished with our treatment within 3 years. Now that's a long time to be in treatment for anybody. But 60% of our children are on the autism spectrum. Am I saying that 60% of the kids we work with are finished, they're cured, everybody's happy in 3 years? No. But they're no longer physically violent. They're no longer in acute danger to themselves or others in terms of safety awareness. They know how to listen to the caretakers who are responsible for their safety. When they hear their name, they orient who's talking. Those fundamental life-saving skills are taught relentlessly as behavioral objectives for the kids on the autism spectrum, and they get it. My staff are with these kids 15, 20, 30, even more hours a week, every week, for years. Who could possibly withstand that level of treatment and not get better? And it's not like we're like this with them. We're trying conscientiously to do it from a farther and farther distance until we're not necessary anymore. The caretakers are still very much involved with their kids, the teacher, various other people, and we work with all of those people to create a wraparound model. I've been on the National Advocates for the National Wraparound Initiative since 2006. I've decided to move on beyond that at this point because wraparound is being marketed to states as an alternative to treatment. Even the guys who created it, Eric Bruns and some of those guys, have now admitted in federal court that wraparound is not a treatment alternative. It's not a substitute. It's a means of managing, negotiating, facilitating the delivery of treatment that wraps around the child. Good for you. But if you put nothing in the wraparound cup, you can wear it for a hat for all the good it's going to do. So the point is, if you put legitimate, supervised, controlled, professionally standardized treatment inside a wraparound cup, it is the answer to a prayer. It can be funded entirely by Medicaid, and that's the short version of what I have to communicate. Any one of you who want to look at it in more depth can certainly contact me. My cell phone is 610-212-0738. The Institute for Behavior Change is the group I formed back in '96 to try to get the word out about this, and their website is www.ibc, hyphen like a minus sign, PA like Pennsylvania.org. So you can go onto that website, download our referral form, and basically I'm pretty transparent about this. I want to show everybody on earth how to do this. And the gratification I get is that people will stop saying, well, you're the only one who does this. Nuts to that. I'm not the only one who should be doing this. And the reason people don't know more about it is sometimes I go to national conferences and I put my material out for distribution, collection by people from various states. It's like a habit. I have to go to the nearest trash can to find my stuff, because people are literally scooping it off the table, I'm not kidding, and throwing it away to keep it out of the hands of parents and advocates. Cross my heart and hope to die, national meetings. It happens, and it's more of a habit than an accident. So what I'm trying to get across here is that there are terrifically powerful forces that are hell-bent on denying people access to EPSDT funding. But there's a bigger dog in the pound, and that is the U.S. Department of Justice, the Office of Civil Rights. And when they get wind of these frankly illegal attempts to suppress access to something that Congress said was a mandate in 1989, now you have a little bit of a balancing act going on, and that's why I want to try to empower you. Your best friend in the search for EPSDT benefits will be the Office of Civil Rights. Let's just clarify what EPSDT benefits are. First of all, they apply to children under the age of 21, and you can get treatment and prevention services, physical, speech, and related therapies, hearing services, eye exams, eyeglasses, durable medical equipment, home, residential, and inpatient care, dental care, and other services, including mental health care. What's missing? This is the most amazing funding source ever conceived. And that's been the list since 1967. 42 U.S. Code of Federal Regulations, Section 1396 DR5, buried within the Social Security Act, you see a description about early and periodic screening, diagnostic, and treatment services. And you can see in here that any services that will correct or ameliorate defects in physical and mental illnesses and conditions discovered by the screening services, whether or not such services are covered under the state plan, is an entitlement under the Social Security Act. Does it have to be a non-experimental treatment? The secret answer to that is no. In Georgia, a federal court ruled that hyperbaric oxygen therapy, HBOT, you've heard of that? It's a controversial treatment that's been applied to kids with autism. It's a 3% increase in the ambient air pressure in a chamber. You're supposedly going to get a higher oxygen content in your blood. Well, a child got that treatment, and they took data before, during, and after, and the data said, wow, this helped. On the basis of that data, it was argued in federal court, and that treatment funding, which can be really expensive, was deemed appropriate for funding under EPSDT. That's an example of creative use of treatment and outcome monitoring.
Yeah, I just wanted to ask, was it just for that kid, or was there some kind of a precedent set for that treatment being used?
Here's the way it works. It was just for that kid. Federal courts don't normally set precedents unless they're class action suits. But the bottom line is, once a federal district court, in the 8th district in this case, ruled in that way, then the other federal district courts can look at it and have their opinions influenced. So it's unlikely that a legislator or a court is going to retreat from the EPSDT standard. And the fact is, since 1967, The EPSDT benefit may have been challenged many times. It has never once been reduced. Sequestration, any of the other things to cut back on expenses and hold on to those tenuous purse strings have never once touched EPSDT. Because it's a civil right. And we look further into it, and you can see that EPSDT funds diagnostic services, preventive services, and also rehabilitative services. EPSDT, you have to understand, it's those services, diagnostic services, recommended by a physician or other licensed practitioner of the healing arts. Notice it says recommended. That allows people under my scope of practice to perform diagnostic evaluations under my scope of practice. These are psychologists in training, or they have other academic credentials that make them eligible to work under my scope of practice. Physicians have a comparable thing with interns. Certified registered nurse practitioners are considered representatives of the healing arts in some states, social workers. So all of those people can do diagnostic evals that would enroll someone in Medicaid and then prescribe EPSDT-based benefits, including behavioral health. And that's what we're talking about down here, rehabilitative services that are designed to restore functioning to children who have lost skills. How many of you know a child who was neurotypical until their first birthday and then lost skills? Every single one of those kids is entitled to rehabilitation services to regain those lost skills without a question. They lost them very young in life, but that doesn't mean they're disqualified. EPSDT is birth to 21. Notice also that it says recommended by a physician or other licensed practitioner. This allows a physician or a psychologist or any other licensed practitioner of the healing arts to supervise the delivery of behavioral treatment services, behavioral health rehabilitation services. That's what I do. The best part is the Affordable Care Act mandates behavioral health services to the population if it's necessary. So then we get into the issue of, okay, well, who determines if it's necessary? In 45 years, the only person who has ever been found legitimate by any court, federal, state, to have an interest in determining the medical necessity of a child's treatment has been the practitioner who saw the child face to face, rendered a diagnosis, and prescribed treatment. And remember I said early on, it says in federal law, the treatment must be sufficient in amount, duration, and scope to reasonably achieve the purpose for which it is furnished. Who determines the purpose for which treatment is furnished? An insurance examiner in an airless, windowless room that reads a report slipped under the door? Are you kidding? That's absurd on its face, and every federal court since 1967 has agreed with that perception. So if you're a courageous practitioner of the healing arts in any state, you can prescribe a BHRS treatment program for your child with autism, ADHD, various other conditions that exactly follows the model that I've put together and I've been billing Medicaid for close to 20 years. If you customize it for that child and add bells and whistles that meet your state's obligations, and those are very readily available on the internet, you can prescribe an EPSDT-funded program for that child, and the only thing the state government can say is, don't tell anybody. Okay? Because if they say, no, we don't do that here, they violated the kid's civil rights. Call the ACLU, the NAACP. There are any number of advocacy organizations that really should take this ball and run with it. But even if they don't, you can contact the local Office of Civil Rights in your state. There's several, usually in large cities. Call them up and say, listen, as far as I can tell, this is an entitlement under the Social Security Act, and I know managed care is trying to stamp it out as best they can, but look, this program will be supervised by a licensed clinician. It is going to be based on standards of practice, including applied behavior analysis. Why would we do anything else? It's going to be rendered by quality people under the supervision of a licensed practitioner. The treatment plan is going to be written in behavioral and objective language. We're going to be able to take outcome data, and even better, we're going to take outcome data every single week from the recipient of services, if not their parent, if they're too young. And on the basis of this prescription, we insist that this is funded for our child under the EPSDT mandate. That's a winning argument. And that's the argument that people in every state have to wage instead of lining up to sign on for mandatory public, or rather private, funding legislation to force the private insurance companies, Aetna, Blue Cross, whatever, instead of trying to force them to pony up the dollars to fund to fund medical treatment, mental health treatment for kids with autism, why not just inaugurate a push to get Medicaid to pay what it's supposed to pay? Right? That's my plea. If we can get Medicaid to fund it, it's icing on whatever other cake exists. So take your private insurance thing, whatever Stephen's Law or Jane's or Bob's or Phil's Law, whatever you got going. 31 states have passed them now. But in addition to all of those, Medicaid remains the payer of last resort. So when you've exhausted the benefits from your private insurance, or if you, God forbid, lose private insurance, Medicaid can step in and fund 100% of the services necessary to deliver treatment that is sufficient in amount, duration, and scope to reasonably achieve the purpose established by the prescriber. Every state has passed a law saying managed care is mandatory in Medicaid, without a question, just to control costs. But managed care has a leash on it when it comes to EPSDT. So what you need to understand is, first, if you have a law passed in your state, you have to bill your private insurance. That's a darn shame, for lack of a better word. The state governments all got behind this movement, sponsored by Autism Speaks and some other loud advocates. We need to balance those scales. Those private insurance companies need to take responsibility for funding autism treatment. Okay, that sounds good on its face, but what do? As soon as you realize Medicaid is a payer of last resort, by creating this artificial imbalance, by saying private should pay, what you do is you make mandatory that Medicaid doesn't have to. And that's the real hidden reason why every state eventually says, sure, those rotten insurance companies should be made to pay. The truth is, what they mean is, that means we don't have to. And that's the part that so many people missed. You have a civil right, an entitlement to treatment of unlimited scope. And you're going to give that up because an advocate or somebody who's being misled or actually being used as a shill is going to advocate for you to give that up and take in its place the privilege of arguing with an insurance company for $30,000 of treatment funding a year. That's a tragedy, you know, and perhaps that's why my stuff gets swept into the dustbin when I try to make it more widely known. It was a mistake. You know, it's a nice idea to balance the scales, but the way it was done, it really benefits private insurance companies because they really don't have a deep investment in it. They can absorb the cost of some kids with autism, even a lot of kids with autism, just by raising their rates for everybody. They're in business, that's what they do. But Medicaid needs to be recognized as a resource that is an entitlement, a civil right for children with autism and other disabilities that cannot be wheedled and twisted and choked out of life. You just need to know where to go to get back up and support. The HMOs all say, or not, actually it's not all of them, there's some of them that are being just stingy, more than they should. And they'll deny an authorization. I ask for 20 hours, they say, tut, tut, you can't have that. Well, there are appeal rights built into the system. So you appeal, and they say, tut, tut, you can't have that. And you appeal, tut, tut, and it gets up to the state Medicaid agency. And now the state Medicaid agency has been put on notice. Listen, this is an entitlement under federal law. You are jeopardizing the state's Medicaid entitlement, all of the state's Medicaid money, by screwing around with EPSDT. What do you gain from this? I'm not prescribing 35, 40 hours a week without data. I have an airtight case. We've been doing this for 20 years. I've been collecting data that if you try to drive a tack with a toothpick, you can do that for the rest of time and it's not going to help. I'm not saying pull out a sledgehammer, but let's balance the child's needs on an individual basis with a prescription that adequately meets them. And in some cases, that's 30 hours a week, 35. And if my data and my background and my experience is ignored in the process of determining the kid's need for treatment, that's a violation of the kid's civil rights. So once the insurance company knows that you're not above calling for help, and the parent's not above making a noise about this, ultimately all they can do is decide at the corporate level, hey look, enough's enough. We're not going to fight these battles anymore. And some of the insurance companies seem to have come to that conclusion regarding the programs I'm prescribing. We don't get arguments, even for relatively high levels of prescription. They have to meet very rigorous standards, but that's not hard. There are some other outfits that I don't know why, but they think they're going to win. Who knows why they think this, but they seem to. And they challenge and challenge and challenge. And so what do? We document and document and document. And it all gets sent to the Office of Civil Rights as evidence. That's all. I'm not doing anything immoral, unethical, illegal, unprincipled. In fact, I'm actually following the Civil Rights Act and making a report of suspected incidents of violation of civil rights that I'm obligated as a professional to make. And there's also a lovely clause within the Social Security Act and the Office of Civil Rights that says I can't be punished for doing that. Now, if I was some kind of an irresponsible whatever, I would prescribe something in a 2-page report and say, yeah, give him 30, okay? And boy, would I be in for it if I did that. Our reports are 12 to 15 pages long. I go to the house to see the kid or to the school and interview the teacher. I'm right there, boots on the ground, eyes in the game. I talk to the mom personally about what we're doing. How satisfied are you with my staff? The short answer is they're ecstatically satisfied. Everybody is getting a little bit better at a little bit, and there are occasional kids that aren't getting better. And at that point, we have to decide, do they have the right staff? Is there oil and water here? It's a great treatment program. It ought to work, but it's not. So we move staff around, try a reassignment, try get another set of eyes in the case. And about 20% of the cases we treat in 4 months are not making progress. 80% are either getting better, the course downward has been reversed in 4 months, or it's stabilized. Now, we can't rationalize a stabilization model for a year, please, even though the EPSDT mandate permits that. Because if I'm prescribing something to, and this is the most important thing to understand, every state has its own definition of what is medically necessary. Pennsylvania's is one of the models held up by George Washington University when they created it, a model fitting the EPSDT mandate. Remember, if a service ameliorates or reduces the intensity of a condition, it is medically necessary. Pennsylvania says, okay, if it treats an existing condition and makes the symptoms get better, or if it prevents the worsening of the child's condition, or if it helps to maintain the child's functioning at a level commensurate with other kids with the same age, etc., then it's medically necessary. So Pennsylvania makes a hole that you can drive a bus through. So what do the insurance companies say? Well, what you prescribed isn't medically necessary, and the only question you have to ask is, okay, pal, how? I prescribed it, and this is in writing in the prescription, to treat his condition, and I prescribed it to prevent the worsening of his condition, and we have evidence that that's true. But in addition, we also prescribe it to help maintain his functioning at a level commensurate with other children of the same age with similar disabilities. Okay, we've met all three, and we only need to meet one. So let's stop quibbling about whether or not this is medically necessary. Stop. The second issue is, well, it's not therapeutically necessary. This is some psychotic vision that insurance companies cook up about, well, okay, it's medically necessary, but 30 is more than he really needs. Yeah, really? Okay, what standard are you using to determine that this is too much? The National Academy of Sciences in 2001 and the American Academy of Pediatrics in 2007 and again in 2012 all said that a child with autism spectrum disorder symptoms needs a minimum of 25 hours of intensive individual treatment every week in order to have a reasonable probability of symptom abatement. So the insurance companies are throwing out the National Academy of Sciences, which has been in existence for 150 years to advise Congress about science matters, and they're throwing out the American Academy of Pediatrics and replacing those opinions with what? A self-serving scheme to reduce or eliminate funding for treatment, and wait for it, the insurance companies can keep 30% of what they don't spend in any given year. Oh my God, I'm seeing this look of shock spreading through the audience. So it's a clear financial incentive, and to some extent the county governments also share in that splitting of the pie of unspent resources. So they get $100 million in January, they have $30 million left over, the county gets 10. You see what I mean? It turns into a money-making scheme that thwarts the civil rights of the children that they are supposed to be helping. And that's why I'm such a popular speaker in the government halls, right? Or the insurance company halls. And my point is, I'm not trying to be an adversary. I'm trying to be correct, honest, ethical, right? It's they that want to deny me that. They want to call me an unscrupulous carpetbagger who's over-prescribing, as opposed to the truth. The government has to keep the insurance companies adequately oiled to keep them in place. That's what you're fighting against. There is a huge amount of money to be made by allowing this secret to be kept. And that's why I'm appealing to people all over the country to stop keeping this so secret. Make an arrangement with your local psychologist, psychiatrist, some mental health provider, a licensed practitioner of the healing arts, to draw up a treatment proposal, a prescription, along the lines of what I created. And you can go to www.treatmentplans.worked.com, and there's 576 treatment plans there that you can download them for the whopping fee of $65. So you download these treatment plans, your local professional customizes them, knowing that every single one of them were funded under the EPSDT mandate. I have a master's degree, by the way. The publication says I have a PsyD. I keep getting these honorary degrees conferred on me because nobody with a master's degree could possibly have any value, right? Okay, so I'm not a psychologist in most states. I mean, there are like 6 that I can legally practice in. So I'm a case manager all around the world. There's no license for that, and I'm not giving psychological advice. I'm not writing treatment plans. I'm simply commenting on what are the standards in the EPSDT Medicaid world regarding treatment plans that might be viable for a given child. So I'll literally hold the hand of a licensed professional to help them accomplish the goal of writing a legit treatment program for a disabled child that will be funded under EPSDT. And that's my whole goal here. And at some point, I'm hoping state governments will wake up and say, okay, these plans are being written. We're going to have to fund these things. We ought to talk to this character with his master's degree and try to get him to help us write statutes, rules, regulations that will keep the unscrupulous practitioners out of the hen house. We cannot deny that the hen house exists anymore. That's not viable. That's been the strategy they've tried to do. EPSDT, Medicaid, BHRS, these are all real things. So the state governments really do need to recognize that there is, in their best interest, a need to create standards for care, and I've articulated what I think they should be. I'd be happy to help any practitioner in any state do what I've been doing in Pennsylvania for 20 years. I got into the network before managed care existed. I started doing this as a private practitioner. I enrolled in Medicaid, filed a service description, did all of that stuff before managed care existed. And I never had anybody complain about anything I was doing for years, so that when the managed care wave came over and everybody was running for cover, I just kind of put my head down and waited until it was in. The truth is, every managed care organization has an obligation under federal and state law to admit providers to the network who offer services, support, things, whatever, that aren't already offered to the membership. Here's your golden ticket to get in. We offer support to families that will apprise them of their rights under the law in the education world, because I'm a certified school psychologist, and that stuff, I can show anybody where that material can be accessed. But not only that, we offer expertise in Medicaid enrollment, Medicaid benefit assistance. Nobody else offers that. So when you come into a network and you say, yeah, I'm a psychologist, you got 400 of them already, but do any of them have expertise in education background? Well, 7. Okay, you got 7. All right, in addition to that, do those 7 have particular expertise in autism treatment? Maybe. Okay, so 6 of them do. Okay, so of those 6, out of the 400 in your group, do any of them know anything about Medicaid advocacy and supporting families' access to Medicaid treatment? And the only answer you're going to get is, huh? Now you provide a valuable service that doesn't exist in the network, and that's how you break in. The state would make itself a whole lot safer if it would just say, fine, we'll let them in. How many people can they hurt? You know? If we complain about those who are perpetrating fraud, waste, and abuse, what we're complaining about is the failure of the existing authorities, meaning the State Department of Public Welfare, to adequately discharge its responsibility to identify such people and to throw them the hell out of the network. When you're committing fraud, waste, and abuse, you're billing for services that weren't rendered. It's not hard to prove that. Especially in a school, for God's sake, get the attendance records. This is how the Office of the Inspector General takes money back from school districts when they bill unethically through the Access program. Schools can tap Medicaid without any insurance oversight whatsoever. Pennsylvania, $140 million last year. Every state, 50 states, over $100 million a year in Medicaid. That's $5 billion every year, tapped by school districts throughout the U.S., tap Medicaid. How on earth does that work? That's another subject entirely, but the bottom line is the state Medicaid authority in every state could identify unscrupulous practitioners in 3 weeks if they wanted to. Audit the records, look at them, make a determination about whether they're actually rendering treatment or not. Does it meet standards of excellence? They can pass standards of excellence. They're going to say from now on we're not going to pay for services unless they're documented in a treatment plan. For the love of God, why not make that a mandate? If you do that, some of the existing practitioners are going to be out of business. And those are the people who are prescribing 6 hours a week for a kid who needs 30. We can't do that. So the bottom line is this whole business of fraud, waste, and abuse. I see people all the time when I go to a school to do an evaluation, my staff are sitting in close proximity to the kid or they're monitoring somehow. There's other kids who are getting treatment like this. The guy's sleeping. How could he be employed? The teacher knows it. Everybody knows it. And he's still coming to work every day. And his provider is getting paid for that. And the teacher and my staff and everybody else is obligated under the law to report fraud, waste, and abuse. So what happens when you call the state and you say, hey, listen, I'm watching Bob sleep every day for a week. I mean, this is a little bit much. Who gets investigated first? The reporter. I know it for a fact because I've experienced the joy of making reports. And it's unnerving to discover that the fraud, waste, and abuse that goes on is not ubiquitous. It's not enormous. There are pockets that need to get ferreted out and fixed, but it's fixable. All you have to do is enforce standards simply, just base standards, and that stuff goes away. You take away the barriers, take out the obstacles, make this work. This is the only way that these kids are going to be saved. I've got a terrific track record that I can help kids with 75, 80% probable success. Now, I make that statement and some of my colleagues in the psychology profession say, wait a minute, that's not causation, those are correlational data, you can't say you fixed them. Right. I can't say that we fixed 1,000 cases. You're right. I can't. Yeah, I've had people challenge me, and they're very literate and very intelligent psychologists. They look at the data we have with a straight face and say, nope, this doesn't prove anything. These are anecdotal reports. Well, every other profession on earth values anecdotal reports to some extent. And there are statistical analyses that say, okay, yeah, it's only correlational data, but you got 1,000 of them, 800 of them got better. You can't say you made them better, but hey, let's face it, 80% of your clientele gets better. Okay, and now we'll wait for the next 1,000 to come through in about a year, you know? And so the days of being able to conceal the fact that BHRS works are over. The data exists. It hasn't been published in peer-reviewed journals. Well, why? The peer-reviewed journals only accept bona fide experimental research where you've got a control group. Well, here's an idea. We're going to take 50 kids. 25 of them are not going to get treatment. And we're going to not tell those parents of what would help their kids. But we're going to treat this group, and then we'll compare them. Are you kidding? You can't do that. That's illegal. It's immoral. But that's the standard that the peer review boards of these journals are holding people to, and sometimes I gotta wonder, what do you gain from doing that? You suppress access to treatment funding and support. Wait a minute, that sounds like you're an insurance company. Ooh. It is what it is. We do what we can with what we got. And I look forward to helping you in any way I can to do more with what you've got. See, now you know, right? Tell everybody, pass my stuff around. Thanks for staying.